We have a great case today. We're going to start with Dr. Filon, who will present, and then we'll move on to a talk on curative therapies or transformative therapies.
Right. Thank you. Let me see if I can work on sharing my screen as well. If not, then I can just present it verbally. But I do have a case. I'm from the University of Miami, working under Dr. Harrington, who's also on this as well. We'll be presenting a case of aplastic crisis with concomitant alloimmunization and treatment options and management in terms of that when it pertains to sickle cell disease. All right. So I will just start off by, I'll just present it then. So this is a 20-year-old male who came to us from a outside facility that was roughly 2 hours away. And we got called as a consult service inpatient for this patient.
I'm sorry to interrupt you, Ernest. I got you set up in this. I might as well just interrupt you. Do you have it? You can't share screen down at the bottom, little green box. Share with whatever slide you have.
Oh yeah, I do see it now. Okay, let's do it this way. Let me see if I can make this full screen.
Yeah, you got it. Yeah.
There you go.
Okay, can everybody see my?
Perfect.
Okay.
Thank you.
All right. Okay.
Yeah. Thank you.
And I'm sorry for the background again. I know that's a vibrant color, but all right. So again, case presentation. This is a 20-year-old male with a reported history of sickle cell disease who presented as a transfer from a facility that was roughly two and a half hours away from our facility, presented with shortness of breath and chest pain. Again, this was a case where, the ER called us pretty urgently to come and evaluate this patient, just given the fact that the acuity of the situation, how sick he was on presentation with them, and the lack of information that both the ED team as well as us had to be able to evaluate him. But again, main complaints that on presentation with chest pain and significant anemia. So for this, on initial evaluation, he was unable to provide us really any history or significant review of systems due to his acuity, due to the acuity of the situation and the severity of pain. Again, the patient was reporting pretty significant retrosternal chest pain that was worse with inspiration and had associated shortness of breath. Again, could not provide us, previous history in terms of whether this patient had acute chest, what treatment he had been on prior to this, or if there were any predisposing factors or symptoms that would have led to this presentation. But again, he was able to report that he had had several days of chest pain without any cough, fever, nausea, vomiting, or other localizing symptoms prior to his admission and then transfer to our facility. All right, so on presentation, vitals for this patient, he was afebrile. Heart rate was elevated between 103 to 110. Respiratory rate was, again, 19 to 28, but for the majority of that evaluation was pretty tachypnic. He was intermittently between hypertensive and normal intensive with the highest reading of 167 over 106, likely associated with this pretty significant pain. And then oxygen saturation, he was saturating around 87% on room air, and then once placed on nasal cannula, had improvement in his oxygen saturation. From a physical exam perspective, again, was in pretty significant distress, short of breath, was only able to give, pretty limited, responses, 1 to 2 words at best. So again, was in pretty acute distress at the time of our initial evaluation. Here are the initial labs for this patient. When he presented in, again, saw pretty significant leukocytosis up to 24.2. A hemoglobin of 3.8, which again, pretty significant regardless of the patient presenting, but does kind of give us a little bit of an idea that, there is something acute going on. Again, without that previous baseline, it is a little bit difficult to interpret, but still significantly low. Platelet count of 357, reticulocyte absolute count of 0.01. So again, not much production by way of that at all. And if I remember correctly, I think his MCV was around 76 or 77. From the metabolic panel listed here, main things to note again was fairly normal for the most part. Bilirubin elevated to 4, but it had normal AST and ALT on that metabolic panel. Additional evaluation that he did have a chest x-ray done in the emergency room. We're not sure if there was previous imaging done at the other facility before he presented, but it did not show any significant like dense consolidations or new effusions on that first x-ray that he had. So again, this posed a pretty difficult situation for us in terms of evaluating this patient, given the fact that we had no previous information to go off of based off of previous hemoglobins. If this patient, previously been on therapies in terms of hydroxyurea or even his pain regimen, and then coming in with this concern for likely acute vaso-occlusive crisis or even a consideration for acute chest, without much information for him. So again, had to try to, make an urgent decision in terms of evaluation. In addition to that, given the, pretty significantly low reticulocyte count, there's additional concern that this patient may have some sort of transient aplastic crisis or aplastic event that is driving his reticulocyte count down. And so the first decision from our end was to try to support him with transfusions as well as pain control and oxygen support. And so again, in the ED, even before consulting with us, they were able to send a typing screen with a plan of being able to transfuse him. But we did get notified from Transfusion Medicine Service that there were going to be some delays and some concerns given the fact that he, potentially has some alloimmunization or some previous some antibodies that could interfere with this matching process. So, like I was saying, again, our main thought was, again, to try to be able to support this patient in the short term. So he received, I think, about 2 doses of Dilaudid 1.5 milligrams, which, again, had not brought his pain down at all. He received those shortly after arriving from his transfer over, unsure of what other pain, management he would receive prior to then. But when we saw him in the emergency room, again, he was, still in very much distress. And so the decision was made to be able to transition him to PCA pump. Again, he was still on supplemental oxygen. And like we said, we started to try to determine, okay, what would be the best step to be able to help this patient. While we were waiting for that, we also did collect a parvovirus PCR to be able to determine whether or not there was a concern for parvovirus is the driving factor for his aplastic event. All right. And so after, I would say, overnight events where we started to do some of this additional workup, we started to get some information from the outside facility that really gave us a little bit more insight into what was going on with this patient. So we were able to find out that he did have a hemoglobin S beta thalassemia compound, and also had a history of papillary thyroid carcinoma with the previous lobectomy the year prior and was on levothyroxine. Addition to that is that he also did have some pertinent past medications, including hydroxyurea, and then also reported that he was taking oxycodone immediate release 15 milligrams. In terms of how often he was actually using that, again, that was still something that we were trying to determine with him in terms of how well his disease has been controlled. But we also we're able to figure out that he has had multiple previous admissions, with the last admission being roughly 2 weeks prior for recurrent pain crisis, and was receiving multiple transfusions throughout that just within this last year. And so based off of that, our transfusion team was able to determine that, his antibodies for previous transfusions, he included anti-C, D, E, K, FYA, FYB, JKB, and S. So again, some concern for heavy alloimmunization in this setting. As parvovirus PCR also did come back demonstrating greater than 5 million international units in terms of that as well. So we were able to demonstrate that he did have active viremia from that, and was likely the explanation for his significantly low reticulocyte count. All right, and so because of all these things, we were, put into a pretty interesting position of a patient that, would definitely benefit from transfusions, again, to be able to help support from the fact that he has no production of RBCs at this time, but not being able to find any matched units for this patient, in that urgent setting with this pretty significantly low hemoglobin, chest pain, and other symptoms and concern for acute chest. And so the decision was made on our end with Dr. Harrington to consider using IVIG as a means to help clear some of the virus that he was producing, in the hopes that this will support the marrow to be able to recover in a quicker rate, while we hope that he starts back making more red blood cells. And so he was started on IVIG 0.5 milligrams per kilogram, and was also continued on IV antibiotics to cover for any possible respiratory infections, and continued with the overall supportive care in terms of oxygen and pain management. And here is the trend in terms of his laboratory values. So what we saw over the course of those couple of days during his admissions, again, improvement in his white blood cell count, kind of expected, again, from an inflammatory standpoint, that that started to improve. Eventually we were able to find 2 units of blood for him, and he was able to be transfused. And so that shows that improvement from the 3.8 hemoglobin up to 5.2. Platelet count, again, mostly unchanged. His reticulocyte count was the main thing we wanted to be able to highlight through this process, is that, on the day of admission was a 0.01. And then we saw improvement from that to 0.11 and up to 0.4. So again, seeing some response with the thought that, this is correlating with clearance of the virus itself. And from a metabolic perspective, we saw this his bilirubin did decrease, but still kind of hovered between 2.3 and 2.8, which maybe correlates with some degree of chronic hemolysis he has, as well as from the transfusions as well. So again, from a hospital course perspective, we did see that this patient had improvement with those transfusions, saw improvement in his reticulocyte count, and we did also see improvement from his respiratory perspective of being able to wean to room air from supplemental oxygen, and was also able to be weaned from his PCA to IV PRN, and eventually, back to his home opioid dosage. And from there was discharged with plan to follow up back with his outpatient hematologist, which was, again, away from our facility. So unfortunately, we didn't really have much more follow-up in terms of, how well his hemoglobin improved over time. Did he require any recurrent admissions or anything like that? And the reason, again, Dr. Harrington and I wanted to bring up this case was just because this is, I guess, somewhat more of an atypical case of having a patient where they have multiple indications for transfusion, but because of the limitations due to the alloimmunization, we weren't able to provide that immediately. And so, again, trying to help support this patient with, looking at the balance of increased destruction and clearance from the chronic hemolysis and impaired production from this aplastic event, trying to figure out what's the best approach in management in that setting. And the thing that, seen mostly from literature review, is that this hasn't been discussed that much. I saw some cases in the pediatric setting where they did discuss patients with chronic hemolysis, or specifically with sickle cell, being able to use IVIG as a means of a supportive measure. But the majority of it was really discussed in, patients that have immunocompromised state. So HIV or other immunodeficiency settings, where they will use IVIG to help that patient clear this virus. So again, just kind of the case that we wanted to be able to highlight in this setting. And if anybody has seen any other cases that, you know, were similar to this or where it has been described in the literature, please definitely let me know as well. And that's all for that case.
All right, great job. Any questions?
Yeah, I just want to emphasize a few things. Thank you, Ernest. Ernest kind of got thrown into this late because there was a confusion on dates, but I appreciate that he got this case ready. We see a lot of parvovirus in this hospital for a large HIV population, a large transplant population. So we have a lot of exposure using IVIG in these patients, and then found there a tick count down the road. This guy was complicated because he was actually sent from ER in Naples to an ER in Jackson, no communication at all. No one knew anything about him. So he came here, and if you look at the alloimmunization that he has, anti-C, D, E, and K, Duffy A, Duffy B, he's got all these things that a good transfusion center that deals with sickle cell patients would not be. They would be crossing these units off to start with, just to not expose them to antibodies. But he got alloimmunized to a wide range, and down Naples area doesn't I wouldn't say it's a sickle cell wasteland, but it's sort of, it doesn't have a lot of good experience there. So they see them occasionally and they may treat them. But in this guy's case, he came in with severely alloimmunized. We were told we weren't going to get any blood on him. Luckily, they got some units late. But the way his reticulocyte count came up in like 3 days makes me think that he may have been kind of on the latter end of his parvovirus. He may have already been kind of clearing it a bit. 5 million is a hell of a lot, but he may have already been sort of in the process of recovery because it doesn't usually respond that fast to IVIG. Well, the retic count doesn't necessarily, but we can't argue with the numbers. So he actually did pretty well. He wasn't a very knowledgeable patient. He was one of several people in this family who had sickle cell, and the care there was kind of a frustrating issue with them. But I'm not surprised we don't have any follow up because this guy doesn't really follow up so well. But it would be nice to know how he's doing afterwards. But he did recover well. And then the next problem was we had to figure out a way to transport him back to Naples. That was our big discharge plans. We had to figure out some transport for him, but ultimately we got a ride for him back there. But good combination of sickle cell related problems with unusual presentation.
From Emory,
Amen.
did you guys consider using EPO for him?
Actually, we check an EPO level on these guys when we consider. He may have gotten EPO, but I think his kidney function was good. We sent off an EPO level. I don't know if Ernest has that value, but we probably did give him EPO too.
Okay. Yeah, sometimes we'll do that in our patients that are difficult to get blood for while we're waiting for the blood.
Yeah, what we generally do with this and a number of different cases, we'll draw an EPO level and then hit them with like 40,000 or 20,000 and give them several days of that, waiting for the EPO to come back. If it comes back at 1,000 or some of these very high levels that they come back. Well, sickle cell patients don't run quite as high. Let's say it's maybe 200-300. They may not benefit as much. We probably keep on going until we see a response, though.
And how long does it take for your EPO level to come back?
How long does it take?
Yeah.
I'm pretty sure this guy came on a Friday night, just because that's how things go. But usually we get an EPO level back in 2 days.
Okay, so you wait for I know because you've talked about your your transfusionless sort of protocols.
No, we don't wait for the results. We actually get, if we draw the EPO level and start treating them, and then we stop based on the result when it comes back, if it's, particularly high.
And we'll often get results back the same day for EPO. I mean, when I see people in clinic on a weekday, I'm getting it back in the afternoon from a morning clinic.
So you guys can do it there.
Yeah, sometimes
Presumably they're doing it there. Yeah, they're making money.
Yeah, actually, that's one of the keys is, I always emphasize these guys, get an EPO level before you start treating them, because they come in. We also have a large Jehovah's Witness population and some sickle cell patients with Jehovah's Witness. So we want to make sure we get these results, because you can spend a lot of money on useless therapy. But
Yeah.
we always start them.
And then, are any other concerns for organ, right? Because the lowest hemoglobin, was it 3, 7?
Yeah,
Or
I think it was.
any brain stuff? Your creatinine was fine, right?
Yeah, he actually came back, mentally came back very good. I mean, I assume it's his baseline. He was not quoting Shakespeare, but he was doing.
Okay,
It was pretty clear.
But no other organ involvement, no renal, no liver issues, and his EPO level was a 401, and that did take about 3 days for it to come back.
Yeah, I think he was a weekend presentation though,
Yes.
which kind of
Friday afternoon.
So this is Bangfu here. Is you just out of curiosity? So when you discharge him to Naples, do they have any form of sickle cell care? Is there anybody that could follow up on him, or they just go and when the next time they show up? How is the system there in Florida?
While he was there, we found the doctor who was involved. Actually, as someone I had been involved in a different hemophilia case a month or so earlier. So I actually knew this guy. He was not very, sickle cell to some extent, but we did discuss the follow-up plans. He just emphasized that he and his family sort of been chronically non-compliant with things. And when he showed up like this, the ER just quickly shipped him over to Miami, which, but I think when he left there, the doctor was supposed to follow, but I don't think he made a close follow-up. Yeah, it's very important.
Well, great case. We're halfway through, so we'll leave time for our presentation. Thank you very much. And
thank you.
What's your future plans, Dr. Filon? I saw you're a PGY4.
Yes, I'm hoping to stay on at the University of Miami and continue to kind of work with Dr. Harrington. Mainly, again, wanted to work within sickle cell. So,
all right. Well, best of luck. There's plenty of other people who try to recruit you away, but good job.
Thank you.
All right, moving on to our case. So we're gonna have a talk today on gene therapy versus bone marrow transplant. Dr. Khemani is right, you've been there 10 years in Atlanta?
Yeah, about 10 years now.
Okay, because your bio
5 years
said,
in the current position.
yeah, your bio said that you're excited to make Atlanta your new home.
Yes. Oh, that's what it says. Sorry.
On the
Yeah,
COA website, I was just doing a quick bio look, so hopefully someday we'll feel like home.
We update that now. Atlanta's been home now for a while.
All right, right. All right. Well, thank you very much for presenting today. We look forward to it.
All right. I'm gonna use Sonia's assistant with forwarding the slides as I was able to finally get it to her, and she'll help me advance the slides on my end. Next slide. Or can I do it on my, oh, there we go. I mean, we're all pretty much familiar with sickle cell disease, but, we can't start a talk without talking a little bit about it. It's basically a single gene mutation in the beta globin gene where the 6th amino acid gets converted from glutamic to valine, causing a hemoglobin A conversion to a hemoglobin S. And the various genetic types include SS, SC, S beta 0, or S beta plus, and a few others that kind of are different that can cause different types of phenotypical consequences of the disease. Next slide, please. So generally, the overview of sickle cell disease is, as we briefly discussed, mutation in the hemoglobin B gene, and it's characterized by the sickling of red blood cells, which eventually can lead to vaso-occlusion, anemia, ultimately leading to organ damage, primarily affecting the African Americans, Africans, Mediterranean, Middle Eastern, and some Indian ancestry. Most of the children with sickle cell disease experience pain crisis, strokes, infections, and early mortality. And the current managements are basically hydroxyurea, blood transfusions, and other supportive care medications. Next slide, please. So what are some of the curative and transformative approaches in sickle cell disease in the pediatric world, which can also be extrapolated for our adult population? So, the curative approach, as we all are aware of, is allogeneic stem cell transplant, or BMT. And then I kind of categorize gene therapy as more of a transformative approach versus a true curative approach. And hence, I make that change in semantics of that. I know a lot of people kind of lump it all together. And ultimately, though, both therapies are aiming to restore the functional hemoglobin production and prevent sickling. Next, please. And just a quick dive into bone marrow transplant. Basically, it involves replacing defective marrow with healthy hematopoietic stem cells from a donor. Requires myeloablative conditioning or chemotherapy to prepare the recipient. And we all know that the best outcomes are with matched sibling donors. However, the common risks that are involved include graft versus host disease, risk of infection, and infertility. Next, please. As for gene therapy, the biggest difference is using your autologous stem cells, which are modified to express functional beta globin or repress sickling genes. In this process, we avoid GVHD as cells are from the patient themselves, but it still requires similar conditioning and hospital stay. Next, please. So one of the things that I have recognized when talking to our patient population and educating the families about transplant versus gene therapy, these are kind of my own anecdotal responses that I put in here, is that gene therapy is a guaranteed cure. But then if you advance it one second. However, we all know that it has promising results, but it's not guaranteed a cure or transformation for all patients. Gene therapy doesn't use chemotherapy. Advance, please. However, gene therapy protocols do require chemotherapy regimens. And this is where I think a lot of patients and families kind of take a step back once they find out that even with gene therapy, they require chemotherapeutic agents, which can eventually lead them to lose their hair and have infertility issues and things like that, which becomes a little bit more of a surprise to the families. And then the other conception was, since using my child's own cells, there's minimal to no risk. Forward, please. Again, reality-wise, although the risk for GVHD is unlikely, but there are still similar risks to organs and fertility and other unknown long-term effects with gene therapy. So this is somewhere I think having further discussions with the patients and the family to kind of go over a little bit of the differences and similarities comes handy. Next slide, please. So in this chart, it's a little bit busy, but I figured for me personally, it was just an easy way to kind of go through the different gene therapy techniques or vectors for sickle cell disease. And I'm not going to go through each one of them, but general concept is basically gene addition, gene editing, and gene silencing approaches to try to restore hemoglobin A, or the other ways is to try to reactivate the pathways to increase hemoglobin F production. And some of the other newer methodologies are to try to decrease DNA damage. So we have all these new versions that are coming up in clinical trials that are available in limited number of spots in different places, but it's promising that there are different approaches that are now being taken with gene therapy to help with sickle cell disease and ultimately other hemoglobinopathies. Next slide, please. And then this one is another kind of, how do you compare bone marrow transplant with gene therapy? Obviously, the big one is the donor requirement. For the bone marrow transplant, we obviously need a matched donor, which makes it really, really hard for some families. conditioning regimens for both of them. Rejection risk is obviously low in gene therapy. And then organ toxicity is similar in both. Infertility is also pretty common in both. And the biggest thing that we want to look at ultimately is the long-term data. Currently, we have a lot more information about bone marrow transplant. There's more late effects data. It's well established. With gene therapy, there's still evolving data that is being collected for most of our patients who are enrolled in clinical trials. And then which ultimately leads down to accessibility and cost and insurance differences that occur for both of these modalities for treatment. Next slide, please. So when we compare the efficacy, BMT with matched sibling donor has approximately 85 to 90% event-free survival. Gene therapy is also pretty good with the 90% reduction in vaso-occlusive episodes. But the long-term durability, we're still under investigation, evaluation, further studies, but ultimately both approaches have improved hemoglobin levels and reducing hospitalization. Next, please. And then just kind of going into accessibility and practical considerations. So again, kind of going back with BMT, we need a suitable donor, which makes it really, really hard because, you have to have a matched sibling that's able to be your donor. And some families have gone to the extent of going through IVF with PGD testing to get embryos and eventually getting siblings to be able to match donor for their patients. The one benefit with gene therapy is that you don't need a matched donor, but you're limited to the clinical trials and availability in select centers, and obviously the extremely high cost. Although there is some approval happening now with some of the other products, but we'll see, it probably takes a while before it kind of takes on for more patients. And then the underrepresented communities obviously face the barriers to both options. So ultimately, we need to kind of expand access and try to reduce costs for these families. Next slide, please. And some of the ethical and psychosocial consideration is that the overall informed consent can be very complex, especially for gene therapy type procedures and techniques, trying to get families to understand the process and how this is all, what happens when we collect the cells from the patient, and going over in some of those details sometimes can get lost. Parents will obviously have to weigh the risk benefits between having limited long-term data versus having a more established long-term data with transplant. And then the other components such as financial, fertility preservation, and overall quality of life. And then, engaging community and genetic counsel is also important. Next slide, please. So these were kind of, again, my own kind of points that I thought were important for us as physicians to provide for our patient population when discussing either of these options or both of these options, where we do our very best to try to explain eligibility and what is currently available in our particular center. And if there is a specific route that the family wants to try to advocate for them at other centers, if there are spots available. Discussing in detail the risk benefits of both approaches and long-term outcomes for both approaches, and setting a realistic expectations. I think a lot of us sometimes are nervous or scared to use the word the potential death from infection or other major organ issues, especially with transplant and GVHD, and how that can be sometimes evolved into a chronic condition subsequently. And then encouragement of participation in trials. We all know that the sickle cell population is a little bit harder to want to participate in clinical trials and be involved in some of these approaches, but providing reassurance to them to let them know that, these are all well monitored and everything will be shared with the family as and when we hear back. And then finally, just providing psychosocial and logistical support as best as we can to these families. Next, please. So what are some of the future directions and innovations that we can try to take as a group of physicians and researchers is like continuing ongoing trials to explore safer non-myeloablative conditioning, CRISPR-based gene editing showing more promise with fewer target effects. I don't know if we would ever get to this, but like a universal donor system where we can maybe overcome HLA barriers and just kind of integrating these options into more of a global health system approach. Next, please. I think these are a couple of my references, and the next slide is about questions if anybody has anything.
All right. Great job. Can you sort of comment on, the numbers you guys are transplant, Emory, sort of what programs you have to improve patient acceptance of transplant?
So we've transplanted over 130 to 150 patients in over the years. Most of them have been matched sibling donors. For the younger population of patients, we have transplanted non-severe cases as well, as long as they've had a matched sibling donor. And most of our patients have done really well. Most of the ones that have had matched sibling donor transplants are thriving and doing great. We have a handful that experienced some late effects of GVHD that have required longer term, sometimes immunosuppressive therapy, plasma exchange therapy, and things like that to kind of help them through the process. But overall, I would say the matched sibling donors, we have transplanted very young patients, and they've all done pretty well so far.
And then where are you guys with reimbursement for gene therapy as a state?
I think we've just heard about I had one patient who was part of Editas, but then had to come off of it and now is go through Casgevy, where it seems like the insurance have approved it, but I have to dig a little bit deeper on how far out we are with the reimbursement for the non-clinical trial-based products.
I think Georgia and Medicaid has said that they'll approve Casgevy at least.
Yeah.
Has anyone had success with having a Medicare patient get approved? I know this is less relevant to the pediatricians in the room, but like a dual eligible Medicare patient?
I don't know the answer to that question. I don't know if Amy is more aware of it, but I don't know the answer to that one. I can follow up and let you know.
Yeah, I'm not sure either.
Yeah, ours is hard, and they're saying until, they're saying from an equal access until everybody approves, they won't let one insurance, patients with one insurance get access where other insurance aren't.
Wait, your institution is saying that?
Yep.
Oh, that's just them stonewalling you.
Right.
Do they do that for liver transplant? If you won't contract with us, we won't give liver transplant for anyone else?
No, I'm sorry. They're saying if all insurances have to improve it before they're willing to move forward, because they say that creates inequity in care.
Oh.
So yeah.
There's a lot of inequity in care that I think is not limited to gene therapy or transplant.
Other questions? Where are other centers at with gene therapy not on clinical trial? Any of the other sites around here?
We've had one, we're doing our first collections for Casgevy, and we've done one patient for beta thalassemia who's been infused, who was 51.
Oh, wow.
Yeah, it was not the one to start with, but he was in great shape. He did quite well with the peri-conditioning stuff.
Any other centers?
Hi, this is Yogi from St. Jude. We don't offer any of the commercial products at this time. We're trying to open or have them available at our center for pediatric patients. But we are offering our own gene editing trial. I think so far we have like 2 patients enrolled.
Okay, nice. All right, anybody else have any more questions about gene therapy or transformative approaches for our expert here? So I know we had the ASH, they had a talk on gene therapy versus alternative donor. Where do you guys stand in terms of alternative donor versus gene therapy? And this was out of
As far as I know, I think we've only had like maybe 1 patient. I don't recall how long ago that we may have done an alternative donor, but then I know I personally had a little girl who had a stroke at a very young age, at like 2 years old and change, and she was the only child. And the parents were very adamant about moving forward with transplant, and we did a haplo on her. But we were wanting to try to do haplo in our center, but unfortunately, the protocol was not opened with us. We had to transfer her care to Nationwide, and she got a haplo transplant over there for stroke indication. And knock on wood, she has done fabulous. She's about 1.5 years out, and we're just working with a little bit of iron overload with her with phlebotomy, and she's responding really well.
Yeah, because we're still waiting, I guess, for the pediatric data, but at least Adetola's data and match unrelated, or sorry, haplo.
Yeah,
seems really promising.
For adult, we're using haplo in sicker patients.
Okay.
And then for kids, we're using gene therapy before haplo. We aren't convinced that the data is as good for kids,
right,
for haploidentical as it is for adults. So we've been, and we're not a haplo center. Like the philosophical bias is not to haplo people because of what they, being cord blood oriented and expanded cord blood and dual cord blood and all of that. So I think it reflects our cellular therapy team on the adult side, and to a certain extent on the ped side.
All right, and Laura in the chat says nowhere in Indiana is doing it for doing gene therapy, so they're going to either Cincinnati or Nationwide. Akshun is saying any locations for adults besides Nashville? Are there age limitations? Where
JJ,
are you? Yeah, Akshun.
thank you. I was just going to comment, JJ. We have actually in the last year had 2 of our kids receive haplo there at Duke. So you guys are doing a couple of those.
Thank you.
I don't know if Akshun wants to say where they're looking for. It says any locations for adults besides Nashville. Are there age limitations?
NIH. For are you talking about for gene therapy or for haplo?
I assume this question from Akshun is for gene therapy.
There's University of Illinois has done a lot of haplo as well.
Yeah, gene therapy. All right. All right. Any other questions? If not, we'll give you 10 minutes back, and thank you very much for both presentations. Appreciate it. And we'll meet again next month.
Thank you.
Thank you.